I would now request Dr. Shanti to give away the compliment and Dr. Sukumar. On the panelists, Dr. K.R. Palanisamy, Dr. Perumanayagam, Dr. R. Surendran, and Dr. Shyam. And the chairpersons, Dr. Sukumar and Dr. Ravi.
Panelists and senior colleagues and my dear friends, it gives me a great pleasure in standing in front of you. At the outset, I would like to thank the Tamil Nadu chapter of Indian Society of Gastroenterology and especially the Salem group of organizers of this conference for giving me this opportunity to stand in front of you. Group of panelists, which is very balanced, having a very senior faculty of medical gastroenterologist and endoscopist, and a very senior surgeon who deals with pancreas, and a young enthusiastic endoscopist who does endoscopic ultrasound, and a good radiologist to discuss all the issues which are related to chronic pancreatitis. The only problem is the time is so short, so we'll try to rush through this. You know that chronic pancreatitis is a very disturbing clinical syndrome where we have pain, exocrine insufficiency, endocrine insufficiency, and complications including cancer. The etiology comes in the West, and in India it's slightly different. In the Western country, the most common etiology is alcohol. When it comes to India, or at least in my state, it is tropical or idiopathic variety. The main issues in management are to counter the effects of this chronic pancreatitis, which the most important is pain, and then you have the exocrine insufficiency and the endocrine insufficiency, and of course management of complication. So we'll start with the case summary of a patient who have been followed since 2003. She's a female, 61 years, and she was initially diagnosed with diabetes mellitus, and she was put on insulin and oral hypoglycemic, and she developed hypertension, and she was on she had hypothyroidism on replacement. She was first seen in 2003, and at that time she was diagnosed to have chronic calcium pancreatitis. She had exocrine insufficiency and endocrine insufficiency, and there is mild weight loss and very insignificant pain. At that time, the imaging showed that pancreatic calculi in X-ray, ultrasound showed dilated pancreatitis with calculi, CT scan again same, and the CA19 was 51, fecal chymotrypsin. At that time we did not have elastase and it was found to be low. So we just put her on good diabetic control and pancreatic enzyme replacement therapy with antioxidants. She was fairly remaining symptom free. This is a CT at that time, and Shyam, if you want to just comment on the CT, that is a 2003 CT and 2004 CT. Quick comment.
So we can see that 2003 CT shows grossly dilated pancreatic duct, and if I have a pointer, so it's very gross, and you can see the pancreatic parenchyma is significantly atrophied, and trying to see if there are any calcifications. Its calcifications are better seen in the 2004 CT because we have some more lower down images.
So the question to you, what is the ideal imaging modality of chronic pancreatitis?
Can we go to the next slide?
Oh, sorry.
One slide before, yeah. So among the modalities available, I think for more information we depend on MDCT and MRI. And we go in a combination of MDCT, during which we give contrast. So contrast enhancement characteristics we look on the CT, whereas MRCP we take the advantage to look for the status of the pancreatic duct.
So it's a combination of MDCT and MRCP is the best modality for diagnosing chronic pancreatitis. Any difference of opinion, audience? Any short comments, quick comments? Perumanayagam, you want to say something?
In a fairly advanced stage of chronic pancreatitis, possibly CT and MR is good enough for most patients. But in the setting of, if you're doubting an early chronic pancreatitis, that getting possibly an endoscopic ultrasound will score over other things, where we are able to look at parenchymal changes much earlier than the ductal changes.
Yes, some studies also have shown that US is quite good for early chronic pancreatitis. Dr. K.R. Palnisamy, so this patient was put on pancreatic enzyme replacement therapy. So can you just tell us in short what are the indications of enzymes in chronic pancreatitis and how do you decide the dosage of that?
The
Very quick.
enzymes we generally recommend when the patient is symptomatic, like there's steatoria, and the chronic pancreatitis, as you are aware, there's more, if the gland is damaged more than 90%, then they develop symptoms like exocrine insufficiency. So there, the replacement of enzymes required in some situations to correct the steatoria. Like if you give enzymes to about 5 to 10% of the pancreatic, if you want to correct by giving enzyme, that's sufficient. So if you have to give, it can be given enzyme supplements to the tune of about 30,000 to 40,000 units per meal. And even with snacks, I think you have to give the enzymes. That should suffice to correct the symptoms.
Does enzymes help in the control of pain?
Yes, it is. In some situation, it might help. That is, especially the pain is related to, the chronic pancreatitis.